Now we have Dr. Gulseth. Dr. Gulseth is a Pharm D, also known as physician's best friend. So Dr. Gulseth, he is the program director for anticoagulation services at Sanford USD Medical Center. He is also a clinical associate professor in the Department of Internal Medicine at the University of South Dakota School of Medicine. Dr. Gulseth received his Pharm D degree in '99 from North Dakota State University in Fargo. He completed his residency training at United Hospital in St. Paul, Minnesota. He is an active member of several professional pharmacy organizations, and he has served on the editorial advisory board of the American Journal of Health System Pharmacy and is past president of Minnesota Society of Health System Pharmacists. He was elected a fellow of the ASHP in 2011 and a fellow of MSHP in 2020. His research interests include evaluation of antithrombotic therapy safety and efficiency and evaluation of the benefits of anticoagulation services. He is the president and owner of Michael P. Gulseth Anticoagulation Consulting, and it's our go-to person for thrombotic therapy. Now this is our second out of 3 lectures on COVID, and this is more focused on anticoagulation in COVID-19 disease. So thank you for giving us this lecture.
Yeah, thank you, Dr. Lupu. So yeah, this is a real honor and privilege to be here, and you know, it's been quite a time for the last 6 months. I think everybody's kind of feels the same way, and I remember the day after the the Oval Office address that happened. I remember driving to work the next morning, and I'm sitting there thinking, boy, stuff's really going to get real now, and I kind of realized what we were facing going forward. And it was kind of a real gut check moment, because there was a lot of interesting anticoagulation issues that immediately raised their heads, even before we had a lot of data that started rolling in from case series and what have you. So I'm going to try to do my best to make sense of a lot of what we've learned through the case of time. Yes, I am going to be crazy enough to get into a little bit of pathophysiology with a group of physicians. I don't know if I'm quite, a little bit insane or what have you, but I'm going to do it my best, because I think that is an important thing that, at least in my opinion, with some of the thromboembolism discussions I'm hearing, I don't think is being talked about enough. And maybe that's because I'm in I'm certainly hang out more in pharmacy circles than medical school circles, but so I'm going to spend a little bit of time about that, and that's going to be the beginning of my talk. Then we're going to move on to talking about some of the laboratory tests that we deal with, looking at coagulopathies and what have you, and I'll try to give a little bit of perspective of kind of how I think about them when I'm working the case. And I should state, when I'm doing this talk, I'm going to do this in conjunction with the patient case as we go along to try to make this a little bit real world. So make sure you have your cell phones out, because we're actually going to use Poll Anywhere to have everybody get a chance to weigh in on what they think they should do with the patient care. Or if you have a computer, you'll be able to do it at your computer screen as well. And then we're going to talk about different thromboembolic prevention strategies and treatment strategies. And I'm going to try to give some perspective as somebody that's not a diagnostician and much more of a treatment person, thinking about what's the optimal treatment in different situations. I'm going to try to provide some of my perspective. So let's get started. Now, I'm going to present a case here. Now, note this case happened before we had high-quality evidence with it, remdesivir and dexamethasone, so everybody's like, why aren't they on those? Okay, well, that was before that. But so some of the hospitalists might recognize parts of this case, but it was a good framework of some of the questions that I wanted to answer, so that's why I'm still going to use it. So RH is a 5'2", 60-kilogram, 70-year-old female, presents with 2 days of worsening shortness of breath, cough, malaise, myalgias, and fever. Her husband was exposed to COVID-19 at work and had also become ill. In the emergency department, she's found to have hypoxia with saturation as low as 84%. She's admitted to further workup and oxygen supplementation, put on 2 liters. Past medical history include hypertension, hyperlipidemia, hypothyroid, osteoarthritis, rotator cuff issues, environmental allergies, GERD, glaucoma, and a GI bleed a couple months ago. Pertinent baseline labs. CBC with differential was unremarkable. CMP was unremarkable, except she had a low potassium. LDH had a slight elevation, ferritin was normal, D-dimer was slightly elevated. Our normal at our hospital is 0.5. So here's your first case question. Which of the following to be the most appropriate strategy for venous thromboembolism prevention for this patient? So you can see there, you need to text Michael Gulseth 934 to, the number is 37607. Again, 37607 is the number you text this to. Again, text it to 37607. If you text that Michael Gulseth 934, it will tell you if you're into the polling system or not. And if you have a computer, you can see the website that you need to go to that'll take you directly in. If you happen to have the Pollinware app, you can also do that. So I'll give everybody a minute to do that, and just go ahead and vote once you're into the poll. So the choices are warfarin titrated to an INR goal of 2 to 3, apixaban 2.5 milligrams by mouth twice daily, enoxaparin 40 milligrams subcutaneously daily, or a full therapeutic heparin drip. Okay, still see some people. I know the first time is going to take just a little bit longer. It'll go quicker after this. Because once you're in, you'll be able to continue to respond. People online, you know, if you're listening to this remotely, you should be able to do this too, so you can absolutely participate. Okay. You got it, Jordan? You voted yet? Okay. I think everybody's in now. So yeah, I think everybody, we had a smart crowd here. That would be your typical response in what we do in this situation. But let's talk a little bit more about some of the logic behind all of this. First of all, let's talk a little bit about COVID-19 and pathophysiology, which I said is probably my biggest trepidation talking to you guys, but I think it's very necessary when we get into this because it cuts to the very core of thinking about why we do what we do and the treatments that we do when we do. Because if you're like me, whenever you're thinking about anticoagulation, we're generally thinking about venous side clots, red types of clots, that's our primary modes of therapy. Where arterial or small microthromboemboli and what have you, more platelet rich, you tend to think about things that are more antiplatelet. Well, COVID-19 does some things that are very unique and very different and are closer to what you see in some of your ARDS types of situations and what have you. So I think we probably all know what COVID-19 stands for at this point, and certainly it's caused by the coronavirus type 2. And I think we probably all know that this enters the host cells by binding to the ACE converting enzyme 2 that's highly expressed in the lung. That leads to alveolar inflammatory cell infiltrate. You get that cytokine storm that we talk about that leads to systemic inflammatory response. And it is also possible the virus itself could cause some hypercoagulability. We don't really have a complete firm answer to that, but I think most experts think it's probably mainly due to this cytokine storm that we see. So a lot of this is due to the inflammatory reaction, and that's probably why dexamethasone, for example, has been shown to be effective, is that it probably helps interrupt that type of situation. This is some interesting autopsy data that looked at patients that had died of COVID-19 versus people with influenza, and they had 7 in each group. And both the COVID-19 influenza group showed diffuse alveolar damage and T-cell infiltration. But the COVID-19 lungs were pretty unique in that they showed severe endothelial injury. Now, Dr. McHale will tell you right away, when we want to start making a blood clot, one of the first things we're going to have is endothelial tissue injury. So that's a very interesting finding. They've then, of course, found thrombosis and microangiopathy, which is what we'd expect. And there was a new vessel growth also noted. So very interesting, very unique even from influenza, what we see with COVID-19. So this is one little schematic that I saw put together in one article that I thought was it made it simple enough for me to understand. So that's why I'd like to share it. So what we see that infection happening, causing that excessive immune reaction. And then that leads to the hypercoagulability and the endotheliopathy that occurs. This also leads to low blood flow at the same time that happens. That low blood flow can lead to hypoxia in and of itself. But then you get the creation of these microthrombosis and the macrothrombosis. And these microthrombosis are literally what they think are one of the big problems that are happening in the lungs of these patients that are actually causing the respiratory problems that we're seeing. We also see the macrothromboses, both venous and arterial, that are occurring. And the thing that's, I think, getting blurrier in my mind when I look at this schematic is what is the difference between the micro and the macro thrombosis? And I think that's one of the things that needs to be focused on a lot more, because I think those macro thrombosis may be perhaps more similar to some of the micro than we originally thought, I guess, and I'll talk about that a little bit more initially. So all this leads to ARDS and hypoxia, and then we can have venous and arterial events that occur in this type of situation. So this leads me into kind of this discussion of what are these events that we're seeing. So the pulmonary embolism, one of the things that really bent my mind a lot when I recently participated in a conference that was put on by the Society of Critical Care Medicine was, what are these pulmonary embolisms? And basically, the key question is, are they embolisms? Okay, because I don't know if we really know the answer to that right now. So there was a recent analysis that looked at CT results from 23 COVID-19 patients with controls of 100 PE patients. And what they found that all the thrombotic lesions were found in lung parenchyma affected by COVID-19. So what do our blood clots that embolize have seeing eyes at this point? That they actually know exactly where that COVID-19 infection is? They also found that the thrombosis load was lower in the COVID-19 patients. They found that, when they talk about most proximal, they're talking about the clot that's most proximal to the heart in these individual patients. They found that the more proximal clots, in the main and the lobar pulmonary arteries were much more common in the non-COVID-19 patients, okay? The COVID-19 patients had much more distal, more types of clots that they were seeing. They found that, and as you would expect with that, the prevalence of an RV to LV ratio greater than 1 was lower in the COVID-19 patient because that you didn't have that right heart strain as much that you see in those bad pulmonary embolism types of patients. Other analyses have showed low rates of concurrent deep vein thrombosis. Of course, we don't know. Maybe that deep vein thrombosis did go to the lung. We don't know that. But yet, that is one of the things. And when I talk to some of the hospitalists I've worked with here, they're seeing very similar things in their patients. They're often not seeing patients with concurrent DVTs. So, and the reason I make a big deal about this is, to me, that could have a big difference in treatment and what our treatment strategies are. And that's why I'm spending so much time on this. Because if it is an in situ type of thrombosis that's coming in the lungs, I'm a little less confident that our traditional anticoagulation strategies are going to be as effective, because that's not the types of clots that we've classically think that they're most effective are. I can't say they won't work either, though, so I want to be very clear on that. We simply don't know. I was very concerned initially when we heard the reports of the people developing pulmonary emboli that were on prophylactic doses of low molecular weight heparin that were developing pulmonary emboli. But that could just be that it's not the best therapy that prevent that type of situation from occurring. And so I think that's an important thing. We got to make a distinction in our head when we're looking at these patients. Now, if you want to get into guidelines and what we're supposed to do, if you want a guideline, I got a guideline for you, okay? Everybody has pretty much put out a guideline. And we are seeing significant disagreement between some of the guidelines as well in my thromboembolism area, prevention and treatment area. And I'm going to highlight some of that. I will refer to different guidelines through this presentation. I'll probably spend the most time with the anticoagulation Pharm guidelines. The reason for that is that's kind of nerdy anticoagulation clinician types of stuff like that folks like me do, that I think they get into some issues that are unique that aren't covered as much by some of the other guidelines because they're a little bit more difficult, insidious types of issues. So I will talk about that, but I'm going to try to highlight where I think I see significant disagreement in some of the guidelines as we go along. So let's talk about the anticoagulation Pharm and what they recommend for VT prevention. They recommend standard dose VT prophylaxis for all hospitalized COVID-19 patients unless contraindicated. Examples would be active bleeding or severe thrombocytopenia. And be sure you consider patient weight. If you have a very large patient, which we certainly do, you probably do need to up that dose. You can't just use 40 milligrams of enoxaparin. you probably need to think about, say, 40 twice a day, or maybe half a milligram per kilogram once a day. But again, that's not great science-based, but that is something we pretty much uniformly do in practice. They did advocate in this guideline for an enhanced VT prophylaxis for the critically ill, and examples included 40 subcutaneous twice daily, half a milligram per kilogram twice a day of enoxaparin, heparin 7,500 units 3 times a day, or low-intensity heparin infusions, okay? And that was based on some of those early data where people were still developing clots on prophylactic doses. And a lot of that came out of Europe initially, and so that's where that came from. They recommend not using biomarkers as sole criteria for enhanced dosing. Now, I'm going to talk about biomarkers here in just a little bit. And then they consider de-escalation in dosing as the patient improves. So then that leads into this question. Does enhanced low molecular weight heparin, is that really appropriate? Okay, because this is a very controversial things between different guidelines. So the ISTH guidelines and the anticoagulation guidelines, they say this is potentially appropriate, okay? If you go and look at like the American College of Chest Physicians or what the NIH has put out, they recommend against it, okay? So there is some controversy here. So it's a controversial issue, as I talked about. I'm less confident in it than I was initially. I was hoping it was the right thing to do initially, but I don't really know at this point. I have less confidence in it. I don't know if it's the wrong thing to do either. And it's just my worry is that if a lot of these things aren't real venous thromboembolism that we're seeing, they're not coming from the venous side of the body, I just simply have less confidence that it's truly going to be effective. No, we do not have rigorous data exploring the safety of these doses, even in normal circumstances, let alone COVID-19. And some guidelines embrace this approach and others do not, as I already talked about. So there's a whole load of trials that are going on out there that are actual randomized trials, so make sure you keep your eyes out for these, because I think these are trials that will make us change practice here at Sanford, because we still have this as an option for our patients because we don't know if it's right or wrong at this point. But when these trial results come on, I anticipate that when these trial results come out, I anticipate we'll definitely be making changes to our practice. So getting back to our case, obviously this patient isn't appropriate for warfarin. I mean, this is a primary prevention situation. Apixaban, we're going to talk about apixaban medical prophylaxis data in a little bit, and it's actually not good at all. Full therapeutic heparin dose obviously would not be appropriate either for obvious reasons. So let's move on and keep going with our patient. So inflammatory and coagulation markers were checked almost daily, including D-dimers, ferritins, LFTs, LDH, C-reactive protein, CBC with differential. On 5/11, the D-dimer trended up to 3.2, which was much higher than baseline, and ferritin was at 328, slightly down the previous day, but over baseline. Patient's oxygen needs had progressed over the last few days, and she was up to 5 liters at this point. So this kind of gets into this, who's critically ill, and where do we start really worrying about a patient? So the question is, are there any changes that are needed to the VT prevention strategy at this point? No, 40 milligrams of enoxaparin is adequate. B, switch enoxaparin 1 milligram. 1 milligram, that should be per day. 1 milligram per kilogram. I put week by mistake there. So that should be per kilogram twice daily. Yes, switch to enoxaparin 0.5 milligram per kilogram twice daily, or yes, switch to a therapeutic heparin drip. And you should just be able to vote this time, and none of that logging in and all that complicatedness at this point. Okay, so most here that are voted are going with that enhanced prophylaxis strategy that we talked about that I said is controversial. And that is something that we have been doing here at Sanford, which was a guideline that I helped work with. And so I can certainly understand that. And when I put this question together, I think you can make an argument for either in this type of situation. We just don't truly know the answer to that question, but continue to watch the literature. So on 5/18, her oxygen requirement increased overnight, leading to evaluation of possible pulmonary embolism. She's up to 12 liters oxygen. There was no PE found on CT, but she had a rather large thrombus within her abdominal aorta with extension into her left renal artery that was found to lead to acute kidney injury. She also had a thrombus within her left tibioperineal trunk with extension into her proximal anterior tibial artery. Most obviously likely an embolism. Vascular surgery was consulted and recommend anticoagulation alone due to they're worried about further embolization if they use thrombolysis in this type of situation. So what would be an appropriate anticoagulation strategy at this time? Would we continue the enoxaparin 40 milligrams daily, increase the enoxaparin 1 milligram per kilogram twice daily, switch to therapeutic heparin drip monitored by anti-10A heparin levels, or D, start rivaroxaban 15 milligrams orally twice daily, which is the DVT dose? Okay, this is a good case. There's some really interesting things here you got to really pay subtle attention to. First of all, it's just, I always like to try to kind of remind ourselves of data where we have high quality data. Do we have high quality data of treating this type of clot? Not that I'm aware of. Okay, so let's just to start there. Okay, so we got to figure this out, and generally we're going to use a therapeutic dose, whatever we're going to do in this situation. This patient's critically ill, and generally we're not going to use an oral agent in this type of situation because we might have to intubate, we might have to put tubes in, or what. There's lots of complications, or they could get, who knows, they could get hemodynamically unstable. It just gets really difficult to use an oral agent. So the options come down to the enoxaparin or the heparin, and generally a lot of the guidelines prefer the enoxaparin to the heparin, but notice she had acute kidney injury too, right? So that really makes enoxaparin not her best option in this case. So really the best option in this specific situation is a therapeutic heparin drip. So a hospital course, you can see here at the 18th, and I'm not going to read through everything here. Her D-dimer did have a big jump that day. That happened. It's probably the most significant thing that you can read there. Heparin drip was so that again that was the day, and again that was the day that we that was the day that we found the clots. By the way, my apologies on that. Heparin drip was started, had a high anti-10A level initially. We titrated down. By the 20th, the patient had progressed in her oxygen needs, transferred actually into the ICU at this point, and her pertinent labs are noted there. D-dimer was up to 3.84. Heparin level was very good. And at this point, the medical team felt she was stable enough to initiate on warfarin at this point. So let's talk about some of the common laboratory findings with COVID-19. I just want to talk briefly about this. Well, first of all, elevated D-dimer, very, very common, and that has been associated with mechanical ventilation, ICU admission, and death. Elevated prothrombin times have also been associated with poor outcomes, and even small elevations, like by 2 seconds of your prothrombin time, can be considered significant. APTT can be depressed by high levels of fibrinogen and factor VIII, which are commonly found in COVID-19 patients actually, which actually leads to some heparin monitoring issues for a lot of facilities, so it's something to think about. Thrombocytopenia may be decreased on admission, may not be decreased. That's actually uncommon. I've rarely seen it, honestly, in my practice. And DIC is rare, but it does occur in severe cases, and that's a poor prognostic indicator. Fibrinogen is often increased initially, and decreased level is a poor prognostic sign. Patients also get lymphopenia, elevated LDH, elevated inflammatory markers that you typically see. Elevated troponin, which is also associated with poor outcomes. And this list is certainly not exhaustive, but that's the things that we've seen in the literature on associations. So we go on to our case. On the 22nd, she'd progressed to needing BiPAP. On the 23rd, she was intubated, and she was still doing poorly, so she had skeletal muscle relaxants given. The heparin drip on the 24th was shut off because we had the INR in a therapeutic range and had been trending up. On the first, she had improved enough to stop cystaceracurium. And looking at her labs on the first, you can see the D-dimer actually had a really big jump that had occurred. So I want to talk a little bit about that. So we're at this point. We have this D-dimer approved. She's actually done a little bit better when you see she's come off the cystaceracurium. She's still intubated at this point, but this D-dimer took a big jump. So the INR was 2.22. Is there any changes that are needed in anticoagulation strategy? No, the warfarin dose is therapeutic. No changes are needed. Just keep going. Yes, keep the warfarin and target a higher INR goal. C, stop warfarin and start enoxaparin 40 milligrams daily. Or D, stop warfarin and restart a heparin drip. What would you do? Okay, pretty much everybody's saying just stick with the warfarin and keep going. Okay? Okay, well, let's talk a little bit about that. And I admit there's one piece of information I didn't give you too, but we'll come back to that. So let's just remind ourselves what D-dimer actually is. And I think this is really critically important, okay? So fibrinogen, when coagulation is activated, creates fibrin. Remember, fibrin is that meshwork that goes in your blood clots, okay? And then plasmin breaks down that fibrin into D-dimers, into these two strands type of situation. So it's a dimer, okay? And so that's what plasmin does. So D-dimer is an indicator that you're depositing fibrin, is what we know, okay? Now let's go back to the pathophysiology that we talked about. The base pathophysiology is probably fibrin deposition, even in these micro circulatory circuits, right? Okay, so you're probably going to be creating a significant amount of D-dimer that aren't from macro clots, macro level clots is what I'm getting at, okay? So it's not specific to a venous thromboembolism. Actually, it's never been very specific to venous thromboembolism. What D-dimer in a normal patient has been known to be useful for is ruling out a DVT or PE, because if it's negative, then it's very, very unlikely to have a DVT or PE. So that's something we got to think about, is where is that D-dimer coming from? It's not necessarily from, say, a macro level clot, is what I really want to stress. Now, D-dimer is a really tricky lab to use, and you really got to have a little bit of an understanding about it, especially when you look at the literature. When I was looking at this literature early on in the pandemic, I was getting confused easily, and I thought I'd note down some things that I thought were important. There's a lot of different testing kits that are available, and specific targets vary in these different testing kits. The methodologies used to calculate D-dimer affect the sensitivity and specificity for DVT and PE. The D-dimer is reported in different ways. I'm not going to get into all that. And even the nanograms per mil, micrograms per mil, milligrams per liter, micrograms per liter, and you'll notice some of those are the same if you're really thinking about it carefully, but yet that gets confusing when you're looking across studies and looking at what your lab is doing and what have you. D-dimers tend to be elevated with age. Some D-dimers are not quantitative at all. And the really important thing to remember is how you use D-dimer really should be determined at the local level and what you're doing at your specific labs. And it's suggested to use roughly 3 to 4 times normal to consider hospitalization, and 6 times normal has been found to be associated with mortality. So how should we, at least how do we use these D-dimer levels, at least what I'm seeing in practice? I think they're often used initially to evaluate initial prognosis. It's strongly associated with risk of death. And D-dimers, prothrombin, platelet count, and fibrinogen are common things that all have some associations, as I talked about earlier. Many follow trends to see if the inflammatory process and hypercoagulation been interrupted. Even that's a little bit controversial. Can you make management decisions off these markers alone? And I would argue that no, absolutely you cannot. You have to look at what's going on with your patient. We just can't be treating numbers specifically. So the anticoagulation guidelines, Pharm guidelines, they make that very clear that it can be a helpful marker to follow, but it shouldn't be the sole criteria, say, to intensifies your anticoagulant dose, and to recommend providers continue to follow biomarker evidence as it accumulates. Now, here's the thing I didn't show you. A couple days before I got that therapeutic INR, we had a couple days where our INR got a little bit low on us. Now, is it low enough to have clearly, caused clot extension? Because we did have the patient pretty well anticoagulated for a while before that. I don't know. And one of the things I'll point out here, it was the patient was on tube feeding. Okay, you notice the tube feeding along the bottom row of this particular graphic. That was the reason we were having a little trouble dosing the warfarin, because tube feeding causes a warfarin resistance that's often not recognized very well. And so we probably weren't aggressive, and I was one of the people doing it, so I probably wasn't aggressive enough as I needed to be there for a couple days. And that led to a little bit of a low INR. And so then that little bit of low INRs for a couple days, so the patient wasn't doing super great, she'd get a little bit better. We did decide actually in that case, and this is looking at the dimer graphics, we did make a decision to go back to heparin. And then the main rationale that when I talked it over with the I think it was the hospitalist that I was working with on this is like, this patient's too unstable right now for warfarin. I want to make sure this patient is doing well, more out of the woods, and is more stable. We got plenty of time to start warfarin later, and so that was the decision that we made, was to go back to heparin drip at that point. So now I want to transition a little bit. I want to talk about some data, okay? I want to talk about the data for post-discharge medical VT prophylaxis. This is probably the most common question I'm getting. Mike, how many people and what people should we send home on medical, post-discharge medical prophylaxis after leaving with COVID-19? And my first, the first thing that always come back to my head is like, well, we got to look at the evidence and what we actually know first in non-COVID patients. So that's why we want to start here. So what I did is I put all the high-quality data that's ever been generated on post-discharge VT prophylaxis with medical prophylaxis, okay? The first trial was the Exclaim trial. That was a low molecular weight heparin post-discharge prophylaxis. And you can see, and I'm gonna focus more on, I know the primary endpoint, a lot of these were all VT, but I'm really gonna focus on the symptomatic rates because I think that's a little bit more clinically relevant. And you can see that it was successful in decreasing symptomatic rates of venous thromboembolism, but it was at the cost of more major bleeding. And so the benefit was considered marginal. Sanofi Aventis did not get the approval for this from the FDA for this indication. Not to mention, this trial was very controversial because they changed the enrollment criteria midway through to make the patients sicker to try to get, because they were going toward futility. So there was a lot of scientific integrity issues with this trial as well. If you look at apixaban actually failed in their comparison, even if all VT, when you compare it to the control. If you go down to rivaroxaban, which I am seeing a lot of people say, well, why aren't you gung-ho to put everybody on rivaroxaban? And I'm like, well, let's look at the data in normal patients with rivaroxaban. So the all VTE is the only place where they saw a statistical difference. So in all VT, so that's going to include asymptomatic distal DVT, okay? Because everybody gets ultrasonography in these types of trials. We don't know the clinical relevance of those types of clots. If you look at symptomatic VT, you can see there really was essentially no difference, and there was clearly more bleeding in the rivaroxaban arm. That Magellan trial is what the FDA approval is based on. It's based on the Magellan trial. Now, they also did another trial, the Mariner trial. In the Mariner trial, they did a little bit different dosing strategy with 10 milligrams a day or 7.5 milligrams through creatinine clearance less than 50. They were hoping to cut down on the bleeding in this trial. It does look like they cut down with their bleeding, but all they did in this is people that were treated however you wanted. They were discharged, they were put on rivaroxaban, or they were put on a placebo. And they didn't show a difference in symptomatic VT in this trial. Now, there is a chance they underdosed the rivaroxaban because the 7.5 milligram arm didn't do very well in this trial. But yet, we don't have a lot of great data for rivaroxaban, even in normal patients, to decrease the rates of VT enough to justify the risk that we're seeing. So, of course, then your next question is going to be, well, Mike, what do we know about COVID-19 patients? Well, there's one case series that I've been able to find that looked at this. 163 patients, the median time from diagnosis to last recorded follow-up of 30 days. They were excluded from the primary thromboembolism prophylaxis on prophylactic anticoagulation, if they were discharged on prophylactic anticoagulation. The median duration of hospitalization was 6 days in ICU. There were 26% that were actually in the ICU. The cumulative incidence of thrombosis, this is both arterial and venous, at 30 days is 2.5%. But if you drill down just to what were considered to be venous thromboembolism, the 30-day post-discharge was only 0.6%, okay? If you look at the 30-day cumulative incidence of major hemorrhage, it was 0.7%, and clinically relevant non-major bleeds was 2.9%, okay? So these are COVID-19 patients, and we didn't really see, when we look at the VT incidence, we didn't see it. Now, you're asking, well, how did they get hemorrhage numbers? Those hemorrhage numbers are just for the people that were discharged on prophylactic anticoagulation. So they looked just specifically at those patients, and they found 0.7%. So obviously there's all kinds of problems with this kind of data if you want to be a data purist, but yet it doesn't show a clear, really high risk of venous thromboembolism when you look at this case series. So what is this leading to in the guidelines? Well, there's guideline disagreement. Some guidelines are very adamant that you shouldn't do it. So, like, for example, the CHEST guidelines and the NIH guidelines recommend against it, or some other guidelines recommend that you can consider it. The thing that I want you to think about as clinicians is you have to anticipate that patient to have a relatively high VT incidence to justify the risk. That's what you need to be thinking about as a clinician when you're making these decisions. So what patients would I be particularly worried about having a clot going home? Well, people that are having to have low mobility, profound weaknesses, not back to baseline, other VT risk factors. Maybe they were intubated, they were paralyzed for multiple days. You know those patients aren't going to be back to their baseline anytime soon. Those would be the patients I would be most interested in doing it on, but I don't think it's all comers by any means. Rivaroxaban would be what my go-to if I do choose to do it. I would just let you know that if you didn't realize it, Janssen is actually being very generous with this drug in this specific indication. They're literally giving it away for free for this indication until the end of the year. We have those vouchers available in pharmacy here at Sanford, and if you don't know how to request these vouchers, just contact me and I'll get you in touch with the folks that you need to get them with. If you can't use Rivaroxaban for one reason or another, such as that really bad kidneys or what have you, well, even enoxaparin would be a problem there, but you could have other reasons. Enoxaparin would be a consideration, but you probably should keep it to 14 days because that Exclaim trial did not have really good data going long term. So let's transition a little bit again here, and let's talk about the importance of using heparin anti-10A levels to monitor heparin when you're using it in your COVID-19 patients. APTT can be prolonged at baseline in a lot of patients with COVID-19. That's something we see people with coagulopathies, what have you. Then conversely, when people have high levels of fibrinogen and factor VIII, which are common in these patients, you can get a heparin resistance that occurs when measured by APTT. And depending on the reagent you used, lupus anticoagulant could cause APT elevation, depending on the reagent. And there were some early reports of that. I haven't seen as much about that now. So the anticoagulation form, they're the only guideline I know that's really weighed in on this issue. They recommend using heparin anti-10A levels over APTT to monitor therapeutic heparin if baseline APTT is elevated. If it's not elevated, APTT can be considered. Note APT elevation could be a sign of coagulopathy, that it could increase the risk of anticoagulation bleeding too. They recommend anti-10A heparin levels over APTT to monitor therapeutic heparin who exhibit heparin resistance by APTT as defined by a need of over 35,000 units over 24 hours. And they're really largely silent on the issue of coagulopathy that could develop if the patient is on heparin monitored by APTT, and heck, that happens even in non-COVID patients as well that can come up. So they don't really weigh in on that, but that's something always we think about. Just remember, APTT does a lot more than measure just what your heparin concentration is, and that's something that's often forgotten by a lot of folks when they're caring for people because they have so many other things they're worried about. So I want to transition a little bit again, and I'm going to talk a little bit about just warfarin and just some of the challenges that warfarin is causing in COVID-19 and some of the issues that I've seen in my practice. So first challenge that that we commonly came up with early on is the patients admitted on COVID on warfarin. It's always been stable. Do you continue therapy? The anticoagulation form suggests the switching to short-acting parenteral therapy because of the case of procedures and clinical deterioration, etc. I will say that actually ISTH actually says that in their guidelines as well. Yet some patients do well and don't deteriorate significantly too, so it makes it's a little bit of a tricky situation. We have some people that are here a day or two and they're right back out the door and they did pretty fine. They did fine. They didn't really progress as we were worried that they were going to. And so it does run into some issues. If you stop it, what are you going to do? We don't have good bridging data with warfarin and what have you, as Dr. McHale would tell you. I know he's a big fan of that, but it gets to be an issue. Challenge number two: are you willing to use DOACs at the usual for the usual thrombosis types, and so for the unusual thrombosis types. So you have this clot in your aorta and you're sending them home. Are you going to use a DOAC? You certainly don't have good data to ever show that it's effective for that type of thing. And some of these patients aren't indicated for DOACs in the first place as well. They might have a mechanical heart valve, for example. When are you going to restart that warfarin? That's a really tough decision. I've kind of come to the conclusion that you got to wait a while generally once you stop. And if you start warfarin in the ICU while a patient's still vented, have you considered the challenges of tube feeding? So I want you to make sure you think about that because that's a real challenge in managing warfarin with tube feeding. I'm not going to talk about that just for the sake of time. I'm going to keep moving here. The next issue, if you start warfarin in the hospital, have you considered the impact of possible drug interactions? You saw in my case that I showed you, they started fluconazole at one point. The reason I got a therapeutic INR again was fluconazole helped me out, frankly, is kind of how I got over the hump again. And so that's something we have to consider. And I would even take this a step further. I'm going to talk about this a bit later, but drug interactions are a huge issue with the direct oral anticoagulants as well in COVID-19 that cannot be ignored. If you start warfarin in the hospital and the patient developed a coagulopathy likely due to COVID-19, what INR do you target? Is the INR reliable? Remember, INR is a validated measure for a patient chronically anticoagulated on warfarin with relatively stable levels of clotting factors, and then looking at their bleeding and thrombosis events, okay? How we use it in the hospital is not how an INR is validated, and that's something that's often forgotten when we're thinking about these types of situations. If you send a new positive COVID-19 patient home on warfarin, have you considered a plan on how the INR testing will occur? And I'm going to talk a little bit more about that in a minute. One of my patients that was brand new, we had really warfarin was the only good option. We had to call the lab in Sheldon, and we found the door we were going to have them go in and how they were going to be in PP and how they were going to do that. We had to construct a whole plan about that. And challenge number 8 for healthy ambulatory patients on warfarin, how do you balance the need to INR testing versus COVID-19 exposure? That's a big one for people that not even have COVID who just don't want to get COVID. So let's talk a little bit, just a quick case study on interpreting the INR in COVID-19. So we have a chronic AFib patient who was recently admitted due to new COVID-19 infection leading to shortness of breath, and it was transient but significant hypotension. Baseline INR on the day of admission was 1.39. Warfarin was continued upon admission. The enoxaparin 40 milligram sub-Q daily was ordered with instructions to stop when the warfarin was over 2. So this patient was on warfarin, but for some reason the INR was really low. The following day, the very next day, the INR is 2.06, along with a T-Billy of 1.7, ELK phos of 400, ALT at 2300, AST greater than 5200, and a D-dimer of 4.36. Hepatology suspected this was due to both transient hypotension that was experienced before admission, but also possibly contribution of COVID-19 to this. So do you stop the enoxaparin in this particular case? So let's see what you guys think on that. Yes is A, B is no. Good, because people kind of thought that I was crazy when I didn't think we should stop the enoxaparin in this situation initially. Is because, yeah, that patient, that's a transient, that was probably due to coagulopathy, that INR jumped. I'm not convinced that patient be really anticoagulated, and it's certainly, again, I know this is not how you should use INR, but it's not at a high enough level yet that I'm really, really concerned about it. If it kept going much, much higher, I might have to reevaluate this, but yeah, we did continue the enoxaparin in this specific situation. So let's transition again. Now let's talk about the patient that doesn't want to get COVID-19 that's on warfarin, okay? Because this is an ambulatory issue that's huge that we had to confront in our anticoagulation clinic. For people that don't know, at Sanford, we have about 2,000 patients that we manage in our anticoagulation clinic on behalf of our primary care physicians and our specialists that are employed here at Sanford. And so this was a big issue that faced us, and we had to decide how we were going to manage these patients and keep them from being exposed. So, the anticoagulation forum did weigh in on this, and a lot of other guidelines did too. And one of the first things they recommended is use a DOAC when appropriate, which is certainly reasonable. They recommend moving stable patients with INRs to 12-week checks because there is some data to support that in your most stable patients. They'd recommend starting drive-in INR testing where there's significant community spread. Work with your facilities and labs to offer testing that minimizes exposure risk. And then, what I would add here is, make sure you consider setting up a robust home INR program if you don't have it already, and expanding that program if you already have one. Many of the federal rules were actually relaxed due to COVID-19 for these types of programs. So we were very, so when we looked at those guidelines at our clinic, a lot of the national experts are like, put them on a DOAC, put them on a DOAC, put them on a DOAC. Well, I'm like, boy, a lot of people can't afford a DOAC still. We run into this all the time. And the number one reason I have a new initiation on warfarin is people don't want to pay their Medicare copays for their DOAC. That's probably the number one reason that we run into. And the manufacturers really offered minimal assistance. I thought they would step up to the plate and maybe try to bridge this type of gap. They really did next to nothing other than what Janssen did with rivaroxaban for VT prophylaxis. The reality is also, on top of this financial issue that we run into, many patients are still not appropriate for DOACs. That's just the plain truth of it. So mechanical heart valves, you can't put on a DOAC. There are some special populations that you could debate, certainly, but we don't generally use it in end-stage renal disease. We don't generally use it in people that are morbidly obese. We don't use it in a lot of those types of special situations. And then there is a lot of interactions with some of the novel COVID-19 therapies. Like, for example, dexamethasone. Okay, that's one of our standard treatments now, right? Dexamethasone is an enzyme inducer. Okay, and it could, in theory, for sure, lead to lower levels of your direct oral anticoagulants. Is it clinically relevant? We don't really know that, but that's just one example, and there's many others as well out there. And so we were very thankful at our anticoagulation clinic that we had a home INR program, because that gave us an outlet, another avenue that we could go down. So this is our numbers from Sanford and how many people we had enrolled in our home INR program. And we made a decision to rapidly increase the enrollment in that program when the pandemic hit. And we enrolled over 200 patients basically in the course of 2 months. So we were very thankful for that. And the thing that was exceedingly thankful is we estimate that we've eliminated over 4,000 COVID-19 exposures for patients, or that we could have put them at risk, and our staff as well, for a risk of catching COVID-19. So that was really helpful. And actually, we presented this program with Sanford, the PI affair, and we won the Tom Braithwaite Award for this because of this type of approach, because that was the type of thing that Dr. Braithwaite always appreciated, were those types of novel solutions that increase quality of care. So now I'm just going to take a step back here as we start to wrap up and just talk a little bit about the human side of this too. I think some of us that are scientists and clinicians, when I took like a Myers-Briggs personality typing, I got a 0 in feeling, okay? And so I almost failed the test if that was possible. But you gotta remember that people are human beings when we're doing this and we're dealing with this. And, there was a lot of fear that we had to confront when we worked with our coworkers and our patients and what have you. But we really had to remind everybody, both the patients and coworkers, we still had delivered care. It's not an option of letting a patient on warfarin never check their INR. And that was something that we continually confronted. I had a patient literally just 2 weeks ago that was actually enrolled in an anticoagulation clinic with the Indian Health Service and what have you. She was so scared to get her INR testing done, she quit. She took herself off warfarin and put herself on aspirin, and she had a mitral mechanical heart valve. Well, you can imagine that she ended up having a date with her CV surgeon, okay? And so these are catastrophic things that can happen when these people aren't managed appropriately. And so, yeah, that's not an issue. And so, we have to make sure that we remind everybody of why we're doing this. It's not just that we want to infect you or infect you as a staff member, that these are real issues that we still have to confront. I think it's really important in stressful situations like this is to try to construct some type of thromboembolism prevention and treatment strategy. That's something we worked with Dr. Lamfers and Dr. Lupu, and we put together what we considered a sensible way to work through this. And I think that helped bring a little bit of clarity in a situation that was clearly chaotic initially. I still don't know if everything we did was the right decision, and we continue to work forward on that, and we'll continue to monitor and change it as we go, but I think that really helps. So if there's any facilities that haven't done that, I encourage you to look at that, and we're happy to share what we've done at Sanford. Avoid warfarin if possible for hospitalized patients, and really don't start until they're relatively stable before they're going to go home. I can't stress that enough. And the same with DOACs. If they're being admitted or they're severely ill and they're on interacting medications, they really need to come off their DOAC temporarily. And ISTH actually specifically talked about that in their guidelines, is stopping the DOACs and warfarin in those critically ill patients. So this will be my last slide. I thank you for sticking with me through all this, but I kind of want to end a little bit with again, I know this is an association study, it's not the highest quality of data, but it really helped, burn in my mind that, boy, this stuff that we do in these decisions we make, man, this stuff's important, okay? And so, the title of this slide was, does anticoagulation really matter? Well, the Mount Sinai Health System analyzed the associations of anticoagulation therapy with in-hospital outcomes. This is a retrospective analysis examining association of anticoagulation mortality, intubation, and major bleeding when anticoagulation was initiated less than or equal to 48 hours from admission. The result was there was just about 4,400 patients that enrolled. Therapeutic and prophylactic anticoagulation associated with a 47% reduction in in-hospital mortality. Therapeutic and prophylactic anticoagulation associated with 31% reduction in intubation. In this particular analysis, there was 2% that had major bleeds. It was higher with the therapeutic dose than the prophylactic dose. And actually, the prophylactic dose was similar to what they saw in people with no anticoagulation. So this was affirming to me. It made me feel good that, well, we're probably on the right track. It's certainly not the highest quality data, but it gives us some confidence that hopefully we're making some of the right decisions going forward. So my key take-home points to wrap up as you go back into your practices here is just a reminder that COVID-19 produces a hypercoagulable condition leading to macro and micro level thromboses, and we don't fully understand what the etiology of some of these clots are that we're calling pulmonary embolisms. Some laboratory parameters have been associated with poor outcomes and may help guide care, but they should never be used to adjust care alone. Choosing optimal anticoagulant prevention and treatment strategies continues to evolve. Systematic pharmacological VT prophylaxis is imperative because that's important even in non-COVID patients. The disease makes monitoring therapeutic anticoagulation challenging, and so you have to make sure you consider what the labs mean in the conjunction of what's going on with your patient. And it's critical to continue to follow the literature, like some of these dosing issues and what have you. We're going to get some good data on this before long, and so we'll have to make modifications as we go. With that, there's my contact information if anybody has any questions, and I'll be happy to take any questions at this time.
Any correlation of, I'll say, pulmonary emboli, whatever they are, when you're on steroids? How do they look at that? Is that decreased the issue?
Good question. Dr. McHale's asking, is there any correlations of, the pulmonary emboli and steroids and what have you? And I guess my response is I haven't seen anything. Doesn't mean that it's not out there. Of course, it wouldn't be high-quality data either, even when we do find it, but that is something that I'd be very interested in to see if, say, that's a good question with the randomized trials. I don't know if that was specifically looked at or not. That's a good question. I should go look at some of those subgroups and see if there is anything buried in there, perhaps. That would be an interesting question.
Are arterial different than venous thrombosis in this situation? I mean, there's venous, there's arterial. I mean, initially they talked about, lupus anticoagulants, anticoagulant antibodies, those type of things, as issues initially they started worrying about these clots, and typically that causes both arterial and venous, but more so is that arterial world, so to speak.
Yeah, Dr. McHale is asking, what about the etiology of those arterial clots? Is this similar to what we see in MIs or what we see in peripheral artery embolisms or what have you that aren't from a AFib source or what have you? Yeah, I don't think we know, and I haven't seen anybody specifically in what I've read get into that specific issue. That's exactly what I'm wondering too. Now, granted, when we have those types of clots in practice now, we do anticoagulate them with heparin. So that's what we're going to do now, but it's a $1 million question going forward.
I just want to say that home INR thing, that was the best thing you ever did. I mean, that was really smart. I mean, going to that was, I can see how that made a huge difference.
Yeah, it was a real team effort. We had a lot of great people at work over there, and they figured out how to do it, and we got our program ramped up, and so yeah, that was smart. I was a little frustrated with some of the national people that were talking about this because they kept emphasizing DOAC, delay INR testing, DOAC, delay INR testing, and I was like, well, not everybody can take a DOAC, and you can't delay INR testing forever, so that's really not a great option either. And when it's if it goes into winter and it's 40 below, a drive-in testing site doesn't work very good either with our instrumentation and what have you. And so I really been trying to promote, and I talked a lot to those guys, promote the home INR testing when you're talking about this, because I think that is one of the better solutions that are out there.
Did you see any benefit in adding an antiplatelet?
Good question. Dr. Loop was asking about adding an antiplatelet. It makes sense. I mean, and I think these are the questions we have to add, because if you're thinking about it like you typically think about Those smaller clots, which tend to be more platelet rich, that would make some sense, but I'm not aware of any good data on that yet at this point. It's a good question. I assume there's got to be some randomized trial out there on that. So, any other questions? Okay, well, thank you very much. Appreciate it.